Everyone, my name is Matthew Webb, and I'm a student physical therapist with a CSCS and a BS in nutrition science. Today, I'm going to be talking about cobalamin or vitamin B12. This is going to be the sixth in a series of educational videos intended for healthcare professionals to help us in direct access healthcare fields become more adept at identifying nutritional deficiencies so that we can get patients presenting with one of these diseases the help that they need. So, without any further ado, allow me to present to you cobalamin, or vitamin B12. So, firstly, we're going to go into the very basics behind deficiency of cobalamin. Then we'll break down the science behind why patients are presenting the way that they do. Then I'll give you some takeaways to help you identify the disease. When a patient has cobalamin deficiency, you may find some notable vital signs and neurosigns. And we'll go further into the science behind these presentations and the risk factors later in this presentation. But I just want to provide you an idea of what we're going to be getting into in this lecture right here. All right, if you watched the folate video, then you've seen this slide before. So this is a DNA slide. If you could turn your attention to the bottom left of the slide, you will see step 1. And slightly to the right of that, you'll see why B12 is important to this function. Now, if you turn your attention to the top left of this slide, you'll see a blown up view of step 1. Step 1 is where dump turns into detemp. Step 2 is seen in the bottom middle of the slide. Detemp turns into detip. Then step 3, as can be seen in the bottom middle or in larger format in the bottom right, detip goes on to be used in DNA synthesis. So let's ask ourselves, what part of the body requires the most DNA and RNA synthesis? Because that's what's going to be impacted by this. If you watch the folate video, then you already know the answer. Do you remember? All right, let's check it out. It's blood. The adult body creates around 200 billion red blood cells per day through erythropoiesis using erythropoietic stem cells. Even though mature red blood cells don't have DNA anymore because they eject their nucleus before entering circulation, it still requires a lot of DNA synthesis to manufacture so many of these guys. Due to the decreased DNA synthesis and cobalamin deficiency, something called intramedullary hemolysis can become more common than not, which is a red blood cell death in the bone marrow. Red blood cells that do manage to live to maturity become large and unshapely, and often they don't successfully eject their nucleus. If you remember the fat water boy analogy from the Foley video, it's like how a fat water boy in sports is going to have trouble getting you the resources you need before the next play. So, this is a slide dedicated to why B12 deficiency in adults is associated with more prominent CNS signs than folate, because folate and B12 are involved in a lot of the same mechanisms, but this is where they differ a little bit. If you look to the bottom right of the Krebs cycle, you'll see methylmalonyl CoA needs B12 as an enzyme cofactor to become succinyl CoA for the Krebs cycle. When B12 is deficient, methylmalonyl CoA and methylmalonyl acid, or MMA, levels rise. High MMA levels have been implicated in CNS myelin breakdown due to abnormal fatty acid being incorporated into myelin. However, this is just one of about 4 proposed mechanisms I've seen for why B12 deficiency impacts the CNS to a greater degree than folate deficiency. It's likely that multiple, if not all, of those mechanisms play some role in the myelin degeneration seen in B12 deficiency. Up at the top right of the slide is a little mnemonic for allegedly someone used for remembering the tracks involved in subacute combined degeneration. However, from my understanding, the spinothalamic tract is impacted nearly as often as the spinocerebellar tract, so I'm not sure that that mnemonic is the best, but whatever. Note that the peripheral nervous system is still usually impacted first by vitamin B12 deficiency for the similar mechanisms to the reason why folate impacts the peripheral nervous system. All right, so you've seen this slide before if you've watched the other deficiency videos, but B12 deficiency is going to impair the methionine cycle, which means homocysteine levels will rise. Homocysteine thiolactone is going to bind to lysine residues in collagen and prevent collagen cross-linking. This means collagen will be inhibited from becoming its stable, mature, insoluble form. All right, so B12 deficiency impacts SAM, the methyl donor, the same way folate does. If you remember the baton pass analogy from the folate lecture, the methyl group essentially gets baton pass to SAM, but this time B12 doesn't make the handoff, and SAM doesn't get to be the methyl donor he was meant to be. SAM's methyl donation is necessary to create the myelin structural molecules phosphatidylcholine and sphingomyelin. Those two molecules are more prominent in peripheral nervous system myelin rather than central nervous system myelin. Note the longer and larger peripheral nerves, such as A beta fibers, are impacted by this mechanism of myelin degeneration first. Here are some risk factors you can look out for. Alcoholism impairs cobalamin absorption due to intestinal damage. Cobalamin is used up in alcohol absorption. Alcohol metabolism. And alcohol acts as a diuretic, increasing urine production, thus increasing cobalamin excretion. Celiac disease is another risk factor because it causes intestinal damage and decreases absorption. As far as drugs go, PPIs can decrease protein breakdown, and since B12 is bound in animal protein due to it only being found in animal proteins, PPIs can be a risk factor for deficiency. Metformin, a diabetes medication, inhibits a protein in the intestines that transports B12 into the body. Methotrexate, a chemotherapy drug, inhibits one of the enzymes in the folate cycle, which can functionally cause uh, B12 not to be able to do its job for the folate cycle. Subjective questions to ask would be about past medical history, and you should make note of celiac disease. Ask them what medications they're taking. Make note of PPIs, metformin, or methotrexate. Ask about any alcohol consumption, and of course, find out what that looks like. Diseases that individuals can be at greater risk for with B12 deficiency are anemia, heart failure, and autoimmune diseases such as Hashimoto's disease. For clinical exam in the integumentary system, findings would be lip ulcers, oral findings would be swollen and red tongue, aka glossitis. Vitals may show tachycardia, which is a common compensation for megaloblastic anemia. Respiratory rate could show tachypnea, which is another compensation for megaloblastic anemia. Note the patient may be more easily fatigable than their history would indicate they should be. And that really is patient specific statement, but it's something to consider. Neurofindings include peripheral neuropathy with sensory signs appearing before motor signs. An example of a finding that cobalamin deficiency could cause would be impaired proprioception and position sense of the ankles bilaterally. And of course, all of this is incredibly similar to folate deficiency. The main takeaways as far as the what, why, and how behind the presentation is that lip and mouth integumentary and oral findings are to be expected as well as vital and neuroscience. The mouth sores and glossitis is due to the collagen inhibition from elevated homocysteine levels. Feel free to read the why on that if you need to, but if you've watched my other videos, you've already heard me say it a million times, so I'll spare you just this once. The vital signs of tachycardia and tachypnea are compensations for megaloblastic anemia, which is due to the impaired DNA synthesis from essentially functional folate deficiency, which is being caused by B12 not participating very well in the folate cycle. The neurosigns are predominantly due to B12 in the form of methylcobalamin not passing the methyl baton, so that it could get to Sam, the methyl donor that wants to donate the methyl group to some myelin structural molecules. This, of course, will mean myelin is going to break down. Note, due to the higher levels of phosphatidylcholine and sphingomyelin in the peripheral nervous system, that means the PNS is going to be what is impacted at a greater degree than the CNS. And here are my resources. Thank you for watching. Note that I am making these presentations during a pretty busy semester, so I'm liable to have made some mistakes. If so, let me know in the comments, and if your corrections check out, then I'll either add it to the video description or I'll pin your comment. If you learned something from this video and you want to learn more, continue on to the ascorbic acid or vitamin C video.